Greetings. Let us learn about cancer of the pancreatic head. As you can see here, pancreas is enclosed in the C-loop of the duodenum and has different sections: head, neck, body, and tail. Here is the head of the pancreas, and as you can see, it is closely related to a number of different structures. The common bile duct drains bile from the liver and goes through the head of the pancreas and enters the duodenum. The pancreatic duct also goes through the head of the pancreas and joins the common bile duct and enters the duodenum. And in addition to these two ducts, the head of the pancreas is closely related to two big vessels. One, superior mesenteric vein, and number two, superior mesenteric artery. So learning about this anatomy is very important, especially to decide whether the pancreatic cancer can be resected by the surgeon or not. We will learn about it a little bit later. So we've learned the normal anatomy, and when the cancer involves the head, it basically keeps on growing and causes obstruction or involvement of the ducts and vessels as well as duodenum. So let us learn about it. Here is a pancreatic cancer. In the initial stages, it may remain silent, may not cause any problems, and that is usually found on a CAT scan done for some other reason. And as the cancer expands and engulfs the bile duct, it results in biliary obstruction. As it also involves the pancreatic duct, it results in blockage of the pancreatic duct. So ductal obstruction happens next. When the bile duct is obstructed, patient's bile doesn't enter into the duodenum, and the bile basically enters from the liver back into the bloodstream, causing the patient to have yellow eyes or jaundice, and they may also have a lot of itching. And because the bile is not entering into the small intestine, they may have clay-colored stools. When the pancreatic duct is obstructed, pancreatic juice is not entering the duodenum. Pancreatic juice is important for digestion of fats, protein, as well as carbohydrates to some extent. And when you don't digest these major nutrients, patients will lose weight. Next, as the cancer is very close to the C-loop of the duodenum, it could result in duodenal obstruction as well. So pancreatic cancer spreads initially locally, engulfing the ducts and the duodenum, and later it could also spread to lymph nodes and vessels. Lymph nodes around the pancreas can get involved, and once there is lymph node involvement, especially away from the pancreas, then that cancer may not be surgically resected. As the cancer gets bigger, it could also involve the blood vessels, the superior mesenteric vein, superior mesenteric artery, other words known as vessel involvement. So we've learned about a lot of different aspects about pancreatic cancer, and for the sake of surgeons who decide whether the patient's cancer could be resected or not, they look at the CT scan and see if the vessel is involved or not. And if there's no vessel involvement, pancreatic cancer can be surgically resected. When there is vessel involvement, they can still resect, but they decide whether the cancer is involving a little bit of the vessel or completely engulfing. That's why this concept of abutment or encasement is used. In abutment, the cancer is basically touching, but not necessarily trying to encircle, as you can see on the right side. When there is encasement, then it becomes very difficult to operate, especially when the artery is involved. So I'm going to show this diagram. This is how the CAT scan of a pancreas looks like. You can see the pancreas in this section. You can also notice the different structures. So you can see on the CAT scan, bile duct, pancreatic duct, superior mesenteric vein, superior mesenteric artery, and the duodenum, like this in the section. And using this section, I want to go through the steps again to help us figure out at what stage the pancreatic cancer can be treated surgically or not. So here is a cancer of the head of the pancreas, just a mass, not doing anything. And as it becomes bigger, it tends to obstruct the bile duct and the pancreatic duct. At this stage, it can be resected. But as it extends further, there is involvement of the vessels, and we talked about vessel abutment or vessel encasement. When there is vessel encasement, then results of surgery are extremely poor, and surgeons may defer doing surgery. In those cases, sometimes they try to do preoperative chemoradiation to see if they can kill off the cells around the vessels before they take the patient for surgery. As the tumor extends further and spreads further, it can cause duodenal obstruction. So we've learned a lot about the different concepts involved with pancreatic cancer, and let us look at a patient. Here is an elderly gentleman who presented with jaundice and has been having a lot of itching. He has lost quite a bit of weight and complains of pain in the epigastrium that radiates to the back. As we know, pancreas is in the epigastric region. And when you do the labs show elevated bilirubin and elevated alkaline phosphatase. CT scan shows a dilated bile duct, enlarged gallbladder, and a mass in the head of the pancreas. This is typical case of pancreatic head cancer. I hope this is helpful. Thank you.